Welcome back to my channel for another video. When we started medical training long back, mitral stenosis was probably the most common isolated valvular lesion seen in the medical wards. But now it is different. As the global population is aging, calcific aortic stenosis of degenerative etiology is the commonest valvular heart disease. Mitral stenosis would have undergone natural attrition of the old cases, and new cases are decreasing because prevalence of rheumatic fever and rheumatic heart disease has decreased globally with economic development. Another variety of mitral stenosis is going to increase now, that is annular stenosis due to mitral annular calcification. Mitral annular calcification occurs in renal failure, chronic kidney disease, and many other conditions. In the elderly, it is more likely to appear in higher numbers as the population ages. Difference between rheumatic mitral valvular disease and mitral annular calcification is that mitral annular calcification is going to be more difficult to manage, while rheumatic mitral stenosis can be simply managed by balloon mitral valvotomy. So when you are thinking of balloon mitral valvotomy, a good echocardiographic evaluation is essential to assess the valve morphology and suitability for balloon mitral valvotomy. During the procedure also, it is helpful to assess success of the procedure as well as to see if there are any complications like increase in mitral regurgitation or pericardial effusion. This is a good diagram of the mitral valve showing anterolateral commissure and posteromedial commissure. Mitral stenosis of rheumatic etiology has commissural fusion as the hallmark. Both commissures can be fused, and in balloon mitral valvotomy we aim to split the commissure rather than the valve leaflet. If the splitting is of the commissural fusion, that will be a good result. If you tear the mitral leaflets during balloon mitral valvotomy, then it is going to produce significant mitral regurgitation. Posterior mitral leaflet, as can be seen here, has three scallops. They are named P1, P2 and P3. Anterior mitral leaflet does not have such well-formed scallops, but corresponding to the posterior leaflet, there are indentations which are named A1, A2 and E3. They are from anterolateral commissure to the posteromedial commissure. That's how it is named. This is more important in case of mitral valve prolapse, where we would like to know which are the scallops which are prolapsed. That's important in repair. In mitral stenosis, we are more concerned about the commissures and subvalvular apparatus. You can see the chordate antennae here. They can also get fused and produce a secondary obstruction below the mitral valve in rheumatic mitral stenosis. If there is severe subvalvular pathology, which can be seen by echocardiogram, then the results of balloon mitral valvotomy may be suboptimal. Now we'll go through some images of rheumatic mitral stenosis and the methods of evaluation of rheumatic mitral stenosis by echocardiography. Doming of the anterior mitral leaflet is seen well and has the appearance of hockey stick. This appearance is classical of rheumatic mitral stenosis. Paradoxical movement of the posterior mitral leaflet is also visible. Normally, posterior mitral leaflet moves posteriorly in diastole. Here there is a paradoxical anterior movement due to commissural fusion. Left atrium is dilated. Left panel shows parasternal short axis view. The mitral orifice is seen within the cross section of the left ventricle. The anterior and posterior leaflets are seen in cross section and are thickened. The commissures are fused. Parasternal long axis view will give an assessment of the subvalvular apparatus. Subvalvular fusion may result in poor results after valvotomy as they can produce secondary obstruction beyond the valve. Parasternal short-axis view is used for quantitating the severity of mitral stenosis by using planimetry to measure the mitral valve orifice. Commissural fusion and calcification, if present, can be seen well on parasternal short-axis view. Parasternal short-axis view in mitral stenosis showing the fish mouth appearance of the mitral orifice in cross-section. Normal mitral valve cross-section for comparison showing anterior and posterior mitral leaflets widely separated. Scallops of mitral leaflets are also visible more clearly in the posterior leaflet. The leaflets of normal mitral valve are thin, pliable, non-calcified and open well in diastole with valve area of 4 to 6 square centimeter. Opening of a normal mitral valve may be reduced in low cardiac output states even without significant mitral stenosis. Echocardiogram in mitral stenosis showing commissural fusion. Parasternal short-axis view showing mitral valve in cross-section and anterolateral and posteromedial commissures. The valve leaflets are thickened and the commissures are fused. The cut is slightly oblique as a good cut should appear circular. It is often difficult to get a good circular outline of the mitral valve due to varying anatomical features of the chambers and cardiac position. Ideally, the smallest full circle should be taken to planimeter the valve area. If it is not a full circle, the subvalvular pathology may be measured as the valve orifice. If the smallest full circle is not taken, it will be the valve proximal to the severest stenosis, that is the valve belly. Mode echocardiogram showing the paradoxical anterior motion of the posterior mitral leaflet in diastole with reduced separation of the leaflets. Anterior mitral leaflet has certain points marked in its movement C, D, E and F. The EF slope is reduced in mitral stenosis. It becomes almost flat in severe mitral stenosis. CD is the closed position of the mitral leaflets in systole and DE is the opening excursion of the anterior mitral leaflet. A wave on M-mode echocardiogram is absent in mitral stenosis. Assessment of mitral valve area by pressure half time involves Doppler echocardiography. A pressure half time of 220 millisecond corresponds to the valve area of 1 square centimeter. Pressure half time is measured from the descent of the E wave in the transmitral Doppler, usually obtained in apical 4-chamber view. PHT is the time taken for the peak transmitral gradient to fall to half its value. It will also correspond to the time taken for the transmitral velocity to fall by square root of 2 as the pressure gradient is proportional to the square of the velocity. Mitral valve area is equal to 220 by pressure half time. In this image, green cursor measures the pressure half time of the mitral stenosis jet. In this case, the pressure half time was 163 milliseconds and the estimated mitral valve area by pressure half time was 1.3 square centimeters. M-mode echocardiogram in mitral stenosis showing the flat EF slope and paradoxical motion of posterior mitral leaflet. Normally, the anterior mitral leaflet shows an M-shaped anterior movement and posterior mitral leaflet shows a smaller W-shaped posterior movement. The upper panel shows the doming of the anterior mitral leaflet in diastole. Mitral stenosis with pulmonary hypertension as evidenced by the flat EF slope of the pulmonary valve M-mode echocardiogram and the shallow A wave marked by the arrow. A mid-systolic notch may also appear in severe pulmonary hypertension. When Doppler echo was not available, M-mode of the pulmonary valve was an important tool to assess pulmonary hypertension.